Hello, my name is Konstantinos Papadopoulos. I'm cardiologist in the Balkan Medical Center in Thessaloniki, Greece. In the next 15 minutes or 20, we're going to talk about left ventricular cardiac mechanics, and especially we are going to analyze the myocardial work, the new method for the performance of left ventricle from the EcoPack workstation of GE. So we all know that strain comes from the helix orientation of the myocardial fibers. In the left ventricle, we have three layers: one subepicardial, one subendocardial, and one between. And we have different rotation of the apex. The apex rotates counterclockwise while the base rotates clockwise. And that way we have the ejection fraction of the left ventricle. It's not only about shortening of the fibers. We should all know that. So what is strain? Strain is how much does an object deform, and strain rate is how fast an object deforms. Why should we use 2D strain for left ventricular assessment when we have the ejection fraction? So strain has a better inter-observer and intra-observer variability. We can detect subclinical myocardial dysfunction. We have many clinical implications in valvulopathies, in cardio-oncology, heart failure, cardiomyopathies, ischemic heart disease. And of course, with ejection fraction, we cannot have an estimation of segmental function, while in strain, we can measure the segmental shortening of every single segment of the 17 segments of the bullseye. Why do we have negative values into the strain? We know that strain reflects the deformation of an object normalized to its size and shape. So while measuring the peak left ventricular strain in systole, the myocardium shortens, and the final length measured is smaller than the actual diastolic size of the myocardial fibers. We have three kinds of strain. We have the longitudinal, the radial, and the circumferential strain. Lots of consensus documents about that. We will not refer to that now. We have many clinical implications. In coronary artery disease, we can appreciate the vessel that has the stenosis. We have different patterns of apical sparring for cardiac amyloidosis, hypertrophic cardiomyopathy with reduced strain of the septum, and patchy reduction of the strain in cases of aortic stenosis. So many implications of the 2D strain in a broad spectrum of cardiac diseases. So apart from measuring the 2D strain in left ventricle, we have a new method which is called myocardial work. And myocardial work includes the afterload of the patient by measuring with the brachial cuff the blood pressure of the patient. So we know that the heart performs work equal to lifting 30 tons of weight from the sea level to the top of Everest Mountain. So what did the team of Otto Smith do? They included into an algorithm the blood pressure of the patient, along with the strain, the GLS of the left ventricle, and they measured these loops of pressure strain. They correlated these loops with the interventional way of measuring the work of the left ventricle, and they saw that we have a very good correlation with the interventional way and the non-interventional and imaging way. So the pressure strain loops correlate very well with the pressure volume loops. And of course, they saw that we have a very good correlation with PET scan in all these patients. And this first attempt of measuring myocardial work was in patients that are receiving a CRT system for mechanical desynchrony. We know that we have several parameters of myocardial work. We have the global work index, we have the global constructive work, we have the global wasted work, and we have the global work efficiency. So we have this loop. On the loop, you can appreciate the event timing. You can see here the mitral valve closure, aortic valve opening, the aortic valve closure, and the mitral valve opening. So what is global work index? Global work index equals to all this area calculated from the mitral valve closure to the mitral valve opening. So constructive work, it is the work that contributes to pump function. So shortening of the myocytes during systole and lengthening during isovolume relaxation. The wasted work is the work that is wasted, as it says. It does not contribute to ejection. We have elongation of the myocardial fibers during systole, and we have shortening against a closed aortic valve. And we also have global work efficiency. It is the fraction of global constructive work to global constructive work and wasted work. You can see here in this loop, we have the pressure, and here we have the strain. We have the whole, the isovolumic contraction. So when the mitral valve closes, first we have the isovolumic contraction. We have a raise of the pressure of the left ventricle. Then we have the aortic valve opening. We have the ejection period. And here you can see that we have the shortening of the left ventricle. And at the same time, we have increase of the strain, goes up to -20. Then the pressure of the left ventricle starts to decrease. And when it reaches the level of the aorta, then we have the aortic valve closure. And then we have the isovolumic relaxation. The pressure of the left ventricle drops very quickly. And then the mitral valve closes, and then we have the diastolic period with a passive filling and the atrial contraction as well. Normal values of myocardial work has been given first from NORE study. We also have some other studies, STAB cohort, and from Elena Galli and the team of Ervan Donal, of course. NORE study gave normal values for the work index approximately 1,900 millimeters of mercury percent. Values for constructive work, 2,200 millimeters per mercury percent. Wasted work of 78, and work efficiency should be more than 96%. About methodology, it is very simple. Let me minimize for a moment my image. Okay. First, we acquire the bullseye for GLS, longitudinal strain. And then you can see on the echo pack that we have a button that says myocardial work. You press myocardial work, and at the same time, you have the event timing of aortic valve and mitral valve closure and opening. What we should do is to go to the ECG tracing, move these bars, trace the opening and the closure of the aortic valve and the mitral valve. Then we should include the blood pressure of the patient that we measure with the brachial cuff. And then we have these loops of the pressure strain. We have the bullseye of work index, and we have these bars. You can see that in these loops, we have two colors, one red and one in green. With red color, we can appreciate the global work index of the left ventricle, while with green color, we can appreciate the segmental work index according to what segment we have chosen from the 17 segment bullseye of this left ventricle. And in these bars, you can appreciate the global constructive and wasted work. Here, this is the global. You can see the wasted work is with blue color, and you can see that this is the global wasted work. it was measured at 300, while the segmental wasted work in this segment, which is the synchronous, and we can understand that by demonstrating this figure of 8 loop of this myocardial segment. So if we have this figure of 8, that means that we have lots of wasted work, and in this segment, the wasted work is even more than the constructive work of this segment. So it does not contribute to the pump function of this left ventricle. On the other hand, if you go, this was the mid-septal segment. If you go, for example, to the basal anterior segment, then you can appreciate that both loops, the red and the green, have a normal distribution, and the bars as well. We have very low wasted work of these segments. Different bullseye for different categories of patients with cardiac diseases. Hypertensive patients have a lot of work because this heart has to increase the performance in order to overcome the afterload of the arterial sclerosis, and this increased afterload from hypertension of the arteries. And these are two different cases. On top, we can see a normal patient with GLS of -20%, and these are the bullseye of work index and work efficiency. You can see that the work index was measured approximately at 2000, while work efficiency was 96%. This is a normal patient. On the other hand, at the bottom side of the screen, we have a patient with ischemic cardiomyopathy. You can appreciate that the GLS is -7%, while we have a work index of 500, work efficiency of 73. So this is a patient with a very reduced performance of this left ventricle. So this is the methodology. You can see here the screen of the EchoPack. And then we have these three apical views: apical 3-chamber, 2-chamber, 4-chamber. We measure the GLS. We all know how to trace the endocardium, have the inner layer into the myocardium, and then we do the correct tracing. We change, if we want, to the region of interest. We appreciate this left ventricle. And then if we like it, we can go to approve and select next. In 4-chamber, at the moment, we will not analyze details of strain imaging, but I just want to show you the methodology. Maybe here we can change a little bit the tracing. Okay, like that looks better. And then we go to 2-chamber again. We trace the 2-chamber view. We don't want to go into the atrial myocardium, just the ventricular at the level of the mitral valve. And then at the panel, control panel, we choose bullseye. Sometimes in the centrum, we can have reduced strain measurements due to the membranous part of the segment. So then we press the button myocardial work of the control panel. You can see that we have this ECG tracing. We have to move the aortic valve closure and opening in this 3-chamber apical view, and at the same time watch at the valves, mitral and aortic, when they close, when they open. And if we have a good tracing, then we should go to the control panel and include the blood pressure of the patient. The first screen shows these two bullseye. of work index or work efficiency. We can choose what to see. And then if we press the advanced button, then we go to this screen with the pressure strain loop, the bars of constructive work and wasted work, and the global work index with the red color, and segmental, whichever we want, with the green color. On the green loop, we can also see the event timing. Here you can see we have a figure of fate demonstration of this segment, which means that perhaps it is the synchronous, but as I told you before, this is the basal anteroseptum. Maybe we have caught the membranous segment. And this is the methodology of measuring the myocardial work. As you can see, it's very easy because it is semi-automated. We just have to include the timing of the valves, and then we have all these measurements. Otto Smith first mentioned that we can use this method in CRT patients in order to find the responders or not. So this paper showed that if we measure global constructive work more than approximately 1,000 at the beginning, or a wasted work more than 380, then we can find the responders of CRT implantation. And you can see that all measurements are better after the CRT. Of course, we should also measure the work difference between the septum and the lateral wall. And in this paper, they also included the viability that they saw from cardiac MRI. And they found out that the combination of septal viability and the work difference, if the work difference between septum and the lateral wall was very big, in combination with viability of the septum, then they saw that with great sensitivity and specificity, they could found the responders of CRT implantation. Again, in this paper, they found out that if patient that is undergoing CRT has a constructive work of less than 1,000, then this measurement can identify the 85% of the non-responders with a very nice positive predictive value. And again, this paper from Otto Smith, again, this team found out that the combination of septal wasted work and wall motion score index can predict the responders of CRT. When we move from the synchronous heart and we go to heart failure, we know from a few papers that myocardial work correlates very well with the prognostic markers, like the NT-proBNP levels of these heart failure patients, the peak VO2 the consumption in cardiopulmonary exercise, and the GLS of this left ventricle. Apart from that, in patients with reduced ejection fraction, if the baseline myocardial work is more than 750, if the myocardial work is more than 750, then these patients have better prognosis, less all-cause mortality, and less hospitalizations. So it's important to appreciate the myocardial work in heart failure patients as well. In coronary artery disease, myocardial work can identify the patients that suffer from severe or significant coronary artery disease. It can predict which patients will recover, which segments will recover after acute myocardial infarction with a nice sensitivity and specificity. And it can also predict which patients will have major adverse events 2 years after acute myocardial infarction. This is a recent publication from the team of Ervan Donal, of course. In this paper, in diabetic patients, they found out that the patients that take double medication with GLP-1 RA and SGLT2, these patients have better increase in myocardial work 1 year after the medication, instead of the patients that take one therapy only or insulin. So we can also use this method in diabetics in order to lead the management. This is one of our studies in patients with secondary MR, reduced ejection fraction, and mitral replantation. We found out that the patients that had constructive work more than 846, which means patients with kind of preserved performance and not very, very much fibrosis of the left ventricle. These were the patients that 1 year after mitral implantation had reverse remodeling with reduced both diastolic and systolic volumes of the left ventricle. In case presentations, this is a typical case. This 66 years old female patient with pulmonary edema, hospitalization, normal coronary arteries, LBBB cardiomyopathy, NIHA class 3 clinical status, full medication for heart failure, and she didn't respond to the treatment. So she came to our lab for further evaluation. You can see the baseline transthoracic echo with septal flash, apical rocking of the apex, and reduced ejection fraction of this patient. Secondary MR due to the synchronous of the left ventricle. The GLS was measured at minus 11%, and we appreciated the myocardial work, and we found out two important features. First of all, this patient had a global constructive work approximately 1,700, which means that the constructive work was very good. We had a left ventricle with nice performance. And secondly, we compared the wasted work of the septum, and you can see here we have the figure of 8, which means that we have a lot of negative work, a lot of wasted work, a lot of dysynchrony, and the segmental work of all other segments. So we have a patient with ECG criteria, of course, for CRT implantation, patient symptomatic, patient with reduced ejection fraction, but at the same time, increased constructive work and huge difference of work between the septum and the other segments. So this was a super responder. She implanted the CRT, and this is the result. You can see that the ejection fraction was more than normal, very good in 3D echocardiography as well. VMR was reduced a lot, and all these parameters of myocardial work were better. This is the global, and these are the segmental. You can see that the segment that was before like a figure of 8, now it's normal, has been normalized, and this is the response after the CRT implantation. In another case, 45 years old female patient, asthmatic, with LBB cardiomyopathy, treatment for heart failure. She came to our lab. This was the transthoracic echo, where you can see again the septal flash, the apical rocking, reduced ejection fraction of these patients. This was after the treatment. We can appreciate that this patient has a heart rate of 100 instead of the beta blockers. And here you can appreciate the reduced ejection fraction, which was measured at with 3D echo at 34%. And the myocardial work showed that the GLS is minus 14%, while we have a constructive work, a good constructive work of 1,700, and a wasted work of 340. These were the segmental values. You can see here the basal lateral. This is the septum, again, wasted work, the figure of 8, a demonstration of the loop. But in another follow-up visit, after a titration of the medication, the patient came with a normal QRS, not broadened, and you can see that there was no desynchronous. Normal ejection fraction, this is the same patient, and it was very important that the ECG was normal at that time. So this was kind of heart rate induced LBB cardiomyopathy, a normal ejection fraction. We didn't do anything in this patient, just we gave the medication that she was taking for heart failure, of course. and heart rate reduction of the heart rate. And these are the measurements from myocardial work. You can see here the global was approximately 1,800. And this is the segment, this in particular is the segment that we saw before, like figure of eight. You can understand the normalization of the pressure strain loop. So this patient didn't proceed to CRT implantation, of course, but she took medication for her case. In order to understand what's the difference of myocardial work from strain, if we have a patient with reduced strain values, segmental, we cannot understand if this is due to akinesia or dyskinesia. Apart from eyeball, we cannot give any other information. We have this patient where you can see we have cardiac amyloidosis. It is a confirmed diagnosis in this patient, where we appreciated the bullseye, where you can see the apical sparring of the apex, reduced values, strain values of the basal segments. GLS was -13, and we proceeded to myocardial work, and we saw that we had a constructive work of 1,500. And you can see now the difference of these segments with reduced strain values. You can see here that this basal septal segment has a loop that it is not reversed, but it is a normal loop, but very narrow. That means that the area that we measure from this pressure strain loop is very low, is very small, and this loop does not contribute to the pump function of this left ventricle. Whereas if you go to other segments, then you can see the normalization of these loops. So this is very important to understand what is the added value of myocardial work when we have a patient with reduced strain values. It is very different to appreciate a patient with desynchrony, a reversed loop, and lots of wasted work. And it is very different to appreciate a segment that it is hypokinetic, for example, or that just does not contribute to the ejection fraction and the performance of the heart. It is better not to contribute instead of having lots of wasted work in these left ventricles. And that's why in these patients, CRT is a definite answer to their problem. So in concluding, myocardial work is a less load-dependent method for LV performance evaluation. And even though it is used for research, it is very promising and it can soon be established. It has already been validated in patients with coronary artery disease and CRT, and we need more studies to validate the method and include it in our routine practice. Before I close this lecture, what I want to tell you is that myocardial work maybe has a restriction when we have right ventricular overload or when we have patients with HFpEF, heart failure with preserved ejection fraction, or patients with very increased diastolic LV filling pressures, or patients that have big remodeling of the left ventricle. These are a few restrictions that I hope in the future we will overcome, and we will be able to use the method in routine practice. Thank you for your attention and have a nice day from Greece.